on the number of deaths reported. They're reported through ONS because we have to collect the data from the death certificates.
So with that, I mean, a good death needs three things. It needs equipment, it needs medication, and it needs the staff to administer it. So in terms of equipment, a few quick questions. Do you have enough syringe drivers in the NHS to deliver medications to keep people comfortable when they're passing away?
Yes, we do.
I've got here, correlate the use of these drugs with COVID deaths, and we'll be looking at the drugs in a minute. Perhaps the most concerning one is Midazolam. So we see 8,000 prescriptions there, about 7,000 prescriptions there. It adds up to an awful lot, and we see an increase in trend in Midazolam prescribing as 21 and 22 went on.
In May 2020, the Pharmaceutical Journal reported that a 2-year supply of Midazolam had been ordered by the UK government from a factory in France. Devon-based manufacturer Accord said that stock ordered by the Department of Health and Social Care in March 2020 had already run out and that they required a further supply. According to the article, the DHSC said the request for extra stock was part of national efforts to respond to the coronavirus outbreak. On the 11th of May 2020, Accord said that the MHRA asked them to make and sell a further 22,000 packs to the NHS. By October 2020, supplies had run out again.
The syringe drivers deliver medication, particularly things like Midazolam and morphine. Do you have any precautions put in place to make sure we have enough of those medications to be delivered?
Yes, we've got a big project to make sure that those sorts of medications, as well as the ITU medications that I spoke about earlier, that the supply chains, the global supply chains for those medicines are clear.
Now, it comes from here. This is from the NICE guidelines published at the time, National Institute for Health and Care Excellence, although the excellent part sounds a little ironic under the circumstances that we're considering. And it was the rapid guidelines for management of symptoms, including end of life in the community of COVID-19. Came out on the 3rd of April 2020. And as we said, these treatment guidelines changed around about then. So to what degree were these deaths here, and some of these deaths here attributable to the way that these interventions were in fact delivered? We normally think of these as end-of-life drugs, but they were prescribed. But the point is, with an infectious condition, you can't tell whether it's end-of-life, unless someone's got some coexisting severe cancer or something. But that would be the vast minority of people who are infected, of course, because some people with really severe infections simply get better. Sometimes because we treat them, other times because we just give them the time to get better. Here, the end-of-life guidelines that have been used and known about for a long time just seem to have been simply cut and pasted into the COVID situation. And that could well be the tragedy that's becoming clear now. How many of these deaths were COVID deaths and how many of these deaths were iatrogenic deaths? Now, iatrogenic means caused by medical treatment. Iatros is Greek for doctor, doctor caused, or any medical treatment. How many people would have survived if the doctors and the nurses had simply not called to see them? It's really, yeah.